Thank you and welcome everybody to the Public Board of NHS England. The session again will be live streamed and we have members of the public invited to observe the meeting. So welcome everybody. We do have some apologies for absence. So we've got apologies from Rakesh Kapoor, who's abroad, from Susan Kilsby, who did join us this morning at the private board, but dialed in from overseas, and from Mark Walport, who actually is indisposed. Vin Duaka is away, but John Quinn is here deputising for Vin, and Steve Parris is away, but Aidan Fowler is here deputising for Steve. I would just like to comment that we are losing 3 of our non-executive directors, that this is their last meeting, and I'd just like to take the opportunity on behalf of the board and many, many colleagues across NHS England just to acknowledge their contribution and to thank them for all their work. So Rakesh Kapoor is stepping down at the end of this year, and he's been a very strong non-executive person, is in particular not just at the board but also sitting on the Audit and Risk Committee and also on DDAT. Susan Kilsby also stepping down at the end of this year, also a member of the Audit and Risk Committee and also the People and Remuneration Committee. And lastly, Munir, who's in the room here. Munir, we will miss you hugely, and thank you for your excellent leadership, actually, of the Quality Committee, as well as the constant contribution you've made to this board and the work of the NHS. Separately, we are, as the board knows, hoping to have approval for new non-executive directors to join the board. We did interview candidates in the first half of July, and are hoping we'll get approval and sign-off certainly before Christmas. Can I then just ask, are there any new declarations of interest from any members of the board since we last met?
There'll be mine added to the formal documents, Richard.
They are, yeah. Thank you, Emily. And actually, that's a very good prompt just to welcome you, Emily. So Emily Lawson is our interim Chief Operating Officer, COO, and it's a real pleasure to have you as part of the team, and we're delighted.
Thank you.
Minutes from the last board meeting held on the 5th of October. Is the board happy if I adopt those, sign those? Thank you very much. Let me move to sort of a broader Chair's update. I mean, we have a helpful agenda, an interesting agenda this afternoon. A couple of things that we discussed at the private board this morning, not on this afternoon's agenda, but we're also very good discussions. One of those is actually reflecting on medium-term strategy and direction and how that translates across into planning guidance. And separately, actually, a very good conversation, which is a continuing theme where Julian and Amanda and the team overall has an increasingly good grip, which is on productivity and on efficiency. The board has met several times since the last sort of formal board, so what we call deep dives, and we've had a number of those. We certainly had a very good session just less than a week ago on winter planning, just updating where we are as we look to winter. We had 2 sessions actually on financial outlook and financial performance, led by Julian, as we looked at the consequences of how we manage with government the cost of industrial action this year, and clearly industrial action will feature later on in this conversation. And then we had a very good strategic conversation about risk appetite, and that was an important conversation, and I think we reached some very thoughtful conclusions. What are we seeing? We're seeing continuing significant lift in demand actually, and also therefore the scale of provision by the NHS. So just some of those demand levels stats that I carry around, that if I look at primary care and the truly excellent job actually that our general practitioners and the workforce in primary care do, they are providing 17% more appointments than in 2019. And we're seeing more than 10% of the population of England, it's about 12%, are having an appointment every week. So 12% of the population has a primary care appointment every week, and of those, almost half, as we know, are provided on the day that the call requesting an appointment is made, and it's over 70% of those appointments are physical, face-to-face, as opposed to virtual. In cancer checks, if I think about that, referrals for cancer checks, we're doing almost 30% more than we were doing, again, pre the pandemic. This year, and even more recently in October, again, we're seeing significantly lifting demand. Amanda may well talk about it, but in October, I think we saw an 8% lift in admissions from the October of the prior year, and we had record emergency department attendance in October, with, I think, 2.2 million people attending A&E or ED in October. And our ambulance Cat 1 and Cat 2 call volumes, call receipts, were, again, the highest we've seen. So the NHS is seeing very significant demand, but is also providing a scale of provision to meet that. Now we're getting into winter. Clearly, we're in winter, and one of the meetings I referred to earlier that the board had actually was with Sarah Jane and Emily, just looking at winter preparations. And there, I think, NHS stands in much better state than it was this time last year in its preparation, but clearly winter, I think, will always be very challenging for us, particularly around, I think, bed capacity. But one stat I would always share is this time last year we were looking at a target of virtual ward build-out, and we've set ourselves a target of 10,000 virtual wards, I think, by end of September. And that felt very ambitious, but actually we hit that, and I think we're now at about 10,700 virtual wards and continuing to develop those further. And clearly we've also added CDCs. I think 40 CDCs have been added in the course of this year. And the other stat I tend to carry in my head is if we look at same-day emergency care, so SDECs, those now are operating 7 days a week, 12 hours a day in 88% of our trusts. So actually, if I think about our capacity and our ability to meet the demand as it comes at us in winter, and I haven't talked about vaccination, where actually, again, we started earlier, and I think we've done 11 million COVID vaccinations and 16 million flu vaccinations, which are the highest we've ever achieved before getting into winter. So there's lots of extremely good stuff achieved. Now, industrial action I have to comment on, but I would defer more, I think, to Amanda. But industrial action, we've already essentially dealt with 40 days, I think, of industrial action across the NHS this year. And I would say that the days chosen now by the junior doctors, they could not be at a worse time. So in the run-up before Christmas and in that first week of January, that's a really, really difficult time for the NHS to manage. I know actually that the NHS will rise to it and will work hugely hard to meet the consequences of that disruption, but actually it will put the NHS under very real pressure. But I know Amanda will say more. Financial pressures are tough at the moment. Julian will give us that update, and particularly also think about financial pressures then running into next year. And those financial pressures also come as much from inflation, which we're seeing embedding, many of us we see embedding across society more broadly, and we will not be, we will clearly also suffer those. Now, I would just like to spend a couple of minutes, if I might, just thanking the board. And within the board, clearly thanking the executives. It's the board in December. I know we work to a sort of a financial year rather than a calendar year, but as one gets into the Christmas month, I always feel it's quite helpful to reflect back a bit. And I think there's been huge achievement, for which I hugely thank the executives and all the people actually working across the NHS. So the long-term workforce plan, we're going to hear about it again this afternoon. It's a major step forward for the NHS, and Navina, under your guidance and leadership, working with the government and with the support of the government, we're now in execution mode. The Federated Data Platform, we'll hear about that. Hugely well done. I think it's a major step forward for the NHS in terms of actually synthesising data across our secondary systems and allowing us to get process improvement. And if everyone wants to think about how to enable AI to bring its benefit, actually having a federated data platform connecting that layer of data, I think, is a very powerful example of it. Electronic patient records now in 90% of trusts. The NHS app now has 33 million subscribers. We do just under 3 million repeat prescriptions every month via the app. It didn't exist 7 or 8 years ago, 6 or 7 years ago. It's transformational in terms of how the NHS interacts with its patients. And in October, we did just over 3 million, 3.2 million appointments on the app into secondary. So actually it's beginning to cross-fertilise across between primary and secondary via a system which actually people are becoming increasingly comfortable in using. More narrowly to us, again, huge thanks to the executives, and I'd like to thank all the workforce of the NHS England as merged, so digital and HGE and X. We've merged 5 entities, 4 boards, and have reduced headcount, so taken 35% of the headcount out. That's put huge stress on the organisation. I have a lot of sympathy for people who've been affected by it, but actually it's a very important debureaucratisation of the centre, and it enables the ICBs effectively for us to devolve more down to the ICBs. Actually, within the regions have actually taken out 40% of headcount. So it's a very important debureaucratisation of the centre's engagement with the systems. But the centre is smaller, but still expert. Electives, I think we had through the year, Amanda made again under your leadership and with Jim Mackey and others. Again, we made significant steps forward in this period. Industrial action clearly broke the trajectory of improvement that we were seeing, and I would hope very much that we'll see a trajectory re-established once industrial action hopefully is sorted. And then lastly, as a theme, and I increasingly talk about this when I go outside the NHS, we sometimes lose sight of just the level of innovation that the NHS sees and implements. And that innovation is utterly remarkable. It's truly remarkable. And there's a phrase you've heard me use before that Amanda taught me, actually. It's a very simple phrase, it was easy to teach, which is the NHS is no longer the NHS of the iron lung. And if you think about the NHS today and think about what it was 3 years ago or 6 years ago or 12 years ago, it is transformed in terms of its level of innovation and the level of treatment and care that it provides to the population. And where are the examples, the more recent examples of that? And my pronunciation is always pretty poor, but we had 2-3 weeks ago an Astrazole, so a repurposed drug. It costs 4p a day, extremely effective in the treatment of breast cancer. Semaglutide, which is the anti-obesity drug. We're very close to a cancer vaccine platform. In genomics, where we are world leading in whole genome sequencing, but actually, as importantly, in single and panel testing, last year we did 700,000 tests, and we're scanning, 700,000 patients were tested, and we're scanning for 200 cancers and 3,200 rare diseases. And then we have other programs, as we know, like Grail Galeri, which is 140,000 population in that testing, that experiment, and that looks to identify over 50 cancers from a blood test. And other than that, we have brilliant technology, evolution. I know our technology in the systems and our data is often very difficult down in the trusts and the legacies, and that we have to focus on improving. But my comments around the NHS app, around FDP, I think they're an important step forward in the way we're thinking about technology. And we also do now have teledermatology for in terms of spotting cancers. We're increasingly using AI in our imaging. So actually, there are real signs of progress here in terms of of innovation within the NHS. And I think it's quite easy sometimes, and I'm not going to get Pollyanna-ish, because our world is extremely pressured, demands are high, our ability to meet the patient's needs, we work really hard to do that. There's lots of stresses in the system, so I'm not being Pollyanna-ish, but we also must not lose sight, I think, of what I believe has been a whole series of achievements, and particularly in the last year and 2 years and 3 years, and that's actually coming through a period of a pandemic. So I circle back to my thanks to the board, but in particular my thanks to the executives and then all of the other managers around the system, as well as to our clinicians and nurses and so on who are providing this level of care to the population. So I think I have probably finished on that, and I'm going to hand over, Amanda, to you.
Thank you very much indeed, Richard. And I'll touch on some of the things you've queued me up for. But just to start by saying that, of course, since our last board meeting, we have seen a government reshuffle. So I've had the pleasure of meeting our new Secretary of State, Victoria Atkins, and I think we all look forward to working with the new ministerial team, as well as some of the ministers who've stayed on in the department, and maintaining a really constructive relationship between the NHS and government. So that's the first thing I wanted to say. I wanted to add, if I may, Richard, to your welcome, a particular welcome to Emily, who, of course, was, can we say you were on loan to...
That is actually what I was.
I think you were on loan to head up the number 10 delivery unit, and now returns to us with a huge amount of delivery expertise from government, as well, of course, as having led the vaccination programme, the COVID vaccination programme here incredibly successfully, and much experience before that. So, Emily, it's great to have you back. I did want to say, if I may, Richard, a bit about industrial action. I know that this is something that other colleagues will then pick up when they're giving their updates. The industrial action announced this week by the BMA, I think, is top of everyone's minds and worry lists, and that is true of us as a board, but also right across the NHS. Since we last met as a board, there haven't been any strikes, and that's because ministers and the trade unions have been in discussions about reaching a pay settlement. And it is worth noting, to your point, Richard, that since the last set of strikes, we've seen improvement every single week in reducing long waits for patients. So it is very positive that the government announced that they and the unions representing consultant doctors in England have reached a position whereby the unions are able to put an offer to members following constructive negotiations. However, junior doctors have this week announced new rounds of action, and that news is obviously incredibly disappointing for everybody involved, particularly because it comes at an already very challenging time for the NHS. We've seen them now in our weekly sit reps, which are starting to be reported publicly. We can see escalating winter pressures with flu, COVID, norovirus. For norovirus in particular, actually just worth noting, we are at a worse point than we were last year. And that is on top of just huge demand across the board. So over previous periods of industrial action, Richard, you've mentioned some of this already, but we have seen not just a significant impact on patients waiting for elective care, but also increased risk to patients who need time-critical care too. And we mustn't forget, I know nobody who works in the NHS ever does, but just forget that behind every postponed appointment or procedure is a patient experiencing added distress, anxiety and pain. So this will be further heightened at this incredibly busy time of year. As we've discussed before as a board, pay is a matter for government, and this dispute is between the government and trade unions. And NHS England's role continues to be to focus on doing everything we possibly can to keep patients as safe as possible and minimise disruption where we can. So we will be working with the wider NHS and engaging with unions to do that. If these strikes go ahead, overall, though, it's worth just saying we will have seen then a full year of strike action if the strikes in December go ahead. So that would mean that across 2023, we'd have had almost 800 hours of industrial action by hospital doctors in total, about 792 hours. And just if you think about that roughly, so that's 9%, so that's almost a tenth of a full year. So our position remains that we respect the right of staff to take industrial action and the decisions of those who choose not to. We value our staff. We absolutely understand that good pay and conditions are important, not only for individuals and their families, but for wider issues such as retention and recruitment, which impact on patient care too. But while many people are preparing for Christmas celebrations, here in the NHS, we have a huge job ahead of us preparing for strikes. So I know Emily and Aidan will talk more about that shortly, but just to reiterate, our immediate focus is to support the NHS to plan to respond to the action and also to discuss with the BMA how to reduce the risk of harm to patients. Over the coming weeks, I just ask all colleagues to bear this in mind. We will be making clear to our patients and the public that they must continue to come forward when they need urgent care. So it's a really important message that we need to continue to give consistently. And we will make sure, and we must make sure that we take time to thank staff who will be covering for their colleagues and doing their best to provide the best patient care that they can. I just finish on this section, if I may, Richard, by just saying, we absolutely cannot have a winter like last year. That was the worst of my own career, and clearly strikes will make this even harder. So I don't think anyone here at NHS England would disagree that what we would like to see, of course, is a resolution to the dispute as soon as possible to prevent any further impact on patient care, which, let's be clear, is an inevitable consequence of strike action. So we would urge all sides to get back round the table to continue negotiations. I'll let others pick up on that because I know that will be a theme, Richard, as we talk. If I just move on, though, for a moment, just to talk about the finance and planning, because obviously financially industrial action has had a big impact this year. We do now have clarity since we last met about how the government want us to deal with those costs from the strike so far. So we have been able to release now hundreds of millions to give straight to systems so that they can prioritise patient safety and urgent emergency care going into winter. Even so, Julian might want to say a bit more about this later, but we do know difficult choices have had to be made and will have to be made nationally and locally to balance the books in this financial year. We are, of course, also having conversations about the next financial year now with government and with systems to establish what credible delivery plans would look like within available resources. Just a few more things I wanted to touch on, if I may. We're going to get deep, I know, shortly into a discussion about winter, because if we think about where the operational focus is right now, maintaining services and patient safety through winter is obviously top of the list. It's not the only thing on the list, but it is top of the list. And as a reminder, we started preparing for winter much earlier than we ever have before. Richard, you've called out some of the things that we've done, things like the virtual ward beds, which are obviously really important pieces of that jigsaw. A key focus has been on ambulance response times, and I know Emily will say more about this, but it is worth, as you said, just noting that whilst there's still more to do and we're absolutely still determined to support the NHS to do the best it possibly can. If we look at the last monthly figures in October, category 2 responses were almost 20 minutes faster than this time last year, and that was despite that additional 8% higher level of admissions. So we continue to deliver our winter plans, and I'm continuing to be really impressed with the determination and engagement of colleagues across the NHS in trying to do their absolute best to be as ready as possible for to look after patients over this winter. At the same time, we're continuing to deliver our winter COVID and flu campaign. So Steve and team have done an excellent job on particularly rolling out the COVID booster campaign and the flu campaign. So we're now at, Steve will correct me if I'm wrong, over 11.4 million COVID boosters and 16.6 million flu vaccines. And there's still a bit of time left to go in our public campaign. That's important because it's about, of course, enabling patients to take the steps that they can take to look after themselves and minimise their own personal risk. It is fair to say, though, I think that we are concerned that uptake rates in frontline health and care workers are, in some places, lower than I certainly lower than they were last year and lower than we would like. So I know that regional teams have been working with those trusts with the lowest rates to understand what further support they might need. Again, that might be something Ruth and Aidan want to talk about when they come in later, because clearly supporting our staff to stay well and healthy over winter is a huge priority for us. You've talked about the FDP. I just wanted to add my thanks to Vin, to Jackie, to Julian, Chris, Emily, all colleagues who've helped get the procurement for the FDP over the line. I do think when we look back at this year, we will see it as one of the most significant investments that we will have made in the future of the NHS, and a really big moment. But we have been really conscious of the need to take people with us on this. So there's been an enormous amount of work to engage colleagues and stakeholders and to ensure a incredibly thorough procurement process over many months. So the real work we know starts here, and I know that Vin and others will be keeping the board up to date, as they will be, and as Ming will explain later, continuing to engage with ICBs, with trusts, to make sure that we are really making the maximum benefit from this from this procurement. Final word, you've said it already, Richard, but we mustn't forget the work that's been going on to create the new NHS England. So we are on track to ensure that by the 12th of December, at least 95% of colleagues know their future role in NHS England. From January then to March, continuing work with any remaining colleagues to match them to available roles and to complete the final phase of the creation of the new NHS England. I think it's worth saying that now the attention not only, and Stephen might want to say more about this, not only has gone on the process, but really on the work to build the culture of the new organisation and to create a sense of really seeing how the value of bringing HEE, NHS Digital, NHS England, as was TDA, NHS Improvement, NHSX, together as one, can really create something new and better in the way that you were describing, Richard. But it is hard work, and it's a tough time for a lot of our colleagues right now. So we will be introducing a new orientation programme for all staff, which will help hopefully to clarify our purpose, values and ways of working as a new organisation. I think that will be another important step in creating that sense of a new organisation. And my thanks to Stephen and colleagues, but also to all of our colleagues in NHS England who have been going through this, for their continued professionalism and engagement and their continued focus on doing what they can to make sure that we're focusing on our primary mission, which of course is to support the NHS to do their best for patients.
Very good. Amanda, thank you. Now, are there any comments or reactions from the board about anything that Amanda said or anything that I said? I mean, do you want to pick up at all, Navina on industrial action or Ruth on industrial action, and reflections in terms of preparation for it?
Well, I think Amanda covered pretty much where our position and how we're supporting government with anything that they need in their talks and negotiations with the BMA. I think Emily will cover impact and preparation. And the preparation for the day for the action.
I would just like just to reflect for a moment, of course, that any additional offer that will potentially go to doctors could lead inevitably to a question of what that means for nurses and midwives. So that will be something, no doubt, that will come through the Royal College of Nursing and the Royal College of Midwives. And we did see their reaction, actually, on the agreement offered to the consultants. We did.
Sorry, Andrew, yeah, please.
So can I just pick up a point on costs? So what does it cost us so far to cover the strikes this year?
To date, to the end of October, our estimate is the direct financial cost about £1 billion.
And that's come out of NHS England resource?
Which has, well, it has come from a combination of funding from the government, the department, some redeployment of capital, underspends, and some decisions, again, from the department to rephase, for example, some of the technology programmes.
And there are indirect costs, of course, not within the direct costs.
Yeah, and the indirect costs in terms of lost activity in patient care of roughly an equivalent size.
And we've rescheduled. We rescheduled about £1 million elective
We
appointments?
think we've rescheduled probably 1 million appointments, and then there's a question, of course, of which appointments never got booked in the first place. So there's a broader disruptive effect.
Yeah, I get it. Thank you.
So if I could just, I mean, this is a hugely difficult area, and I know colleagues across the board are working very hard both to mitigate the impact, but is there a way of establishing, from this board perspective, which is, of course, looking at patient safety and whether there's been an impact, how that impact's been? Because as this goes on, and, you know, Ruth, if you're suggesting, as they said, the nurses might continue, then what does this mean for how we go forward?
Amanda, Aidan, patient safety. Do you want to try and pick up? I mean, how do we think about?
Yeah.
And clearly, it's a very
it?
sensitive area, but it's a very major disruption to the NHS operations. So how do we think about that?
So like others, I'm obviously concerned about industrial action and its impact on patient safety, and particularly at a time where we would expect to see significant winter pressures.
Yeah.
I think there are several things that are really, really important to say. So firstly, to recognise the enormous amount of work that colleagues do in stepping up and doing everything they can to mitigate that risk. They've worked incredibly hard. That, particularly for the next round of industrial action, means our senior medical colleagues. The next point is that we are clearly working with the BMA, and that relationship is critical. It's important that we maintain dialogue about how we work together to minimise the risk to our patients. Third important point for patients is the need to step forward when they are unwell and need care, regardless of whether there's industrial action. We do not want people being put off. We recognise that harm is unequally experienced by some of our communities, and there are particular communities that we have feedback see this reported and feel they have to care for their own relatives when actually they should be attending.
They should come forward.
So that's an important point. The other thing is that, of course, this isn't the first industrial action, as has already been said, and so what we are doing is looking at previous experience to see if there are any gaps, to see if there are any other areas where we can do more to mitigate risk. For example, making sure that those particularly cancers that are rapidly progressive and require surgery are not delayed. In the world of transplant, there's been a big focus on solid organ transplant. I think with less of a focus on, for example, corneal transplant, we've not been aware of losing any tissues so far, but it would be a tragedy to do so because of this, so we're focusing on that. Ruth will probably want to talk about maternity. We need, obviously, to look at what goes on in mental health and how we make sure that patients don't miss out on important changes to their care because of it. And so there are a number of areas that we can identify where we will talk to the BMA and others about how we support those to make sure we're minimising the risk based on previous experience. I think the other thing, and it's to this point about people stepping forward, is we have from time to time in industrial action seen some unscheduled, as in emergency care, dropping off, which is of concern. For example, in cardiac, if we start to see that levels of attendance are dropping off, that's an important point for us to make sure our messaging is very clear that we are open for business.
Thank you. Do you want to comment on maternity, Ruth? Or?
I would, thank you, Chair. So when you talk about elective operations could be cancelled as a result of industrial action, we'll need to make sure that elective sections aren't cancelled. It's a tragedy for somebody to wait an extra 6 weeks to have their hip replacement, but it'd be very different having to wait an extra 6 days for having an elective section. So these are really important. We will work with the BMA on a daily basis, hourly basis if we need to ensure that doesn't happen. But this will need a lot of effort from medical directors, chief nurses, lead obstetricians, lead midwives across England to ensure that we keep women, babies safe during this. But you know, medical directors, nurse directors are working extremely hard through this.
And managers actually to manage rotas.
They are really working very, very hard, as well as all of our clerical teams, rescheduling and the like. So hats off to them because they work very hard.
Thank you. I think we should move on into operational performance update and more broadly, and perhaps also with a focus of readiness as far as we're able to be for winter and what we're seeing. That would be really good, Emily. Thank you.
Thank you. So the published paper contains data for both October and September, depending on the area, given the time taken to produce published data in different areas. So I won't go through the whole paper, which I'm sure people have looked at, but just pick out a few of the operational highlights and then we'll look ahead. So what we can see in the data that October was indeed a challenging month, as Amanda and Richard have both referenced. We had 1.4% more attendances and 8.7% more emergency admissions via A&E. So we were proud that even given that, the 4-hour ambulance performance was at 70, so at the A&E performance was at 70.2%, and the category 2 performance at 41 minutes and 40 seconds, which is nearly 20 minutes faster than last year, despite 7% more incidents. So indicating, as I think Amanda said in her introductory remarks, that we are in a better position going into this winter than we were last winter. It's not just in A&E performance and emergency performance. So despite industrial action in both September and October, the elective programme was able to make progress on some of our targets while others sort of held steady. So 104-week waits and 65-week waits basically held steady. They decreased marginally over that period, but the 52-week waits decreased by 5,521 waits to 391,122. We do recognise, however, that over the same period, the 78-week waits have increased. In March, the end of March this year, we reduced that below 10,000, which was regarded as effectively being eliminated. And at the end of September, they were at 10,201, so they've gone up above 10,000 again. So I'll come back to the planning work that the finance and operational teams have been doing and talk about how we propose to tackle that. On cancer, the urgent suspected cancer referrals first seen and the first treatments were 30% and 7% above pre-pandemic levels, respectively. And the performance against the faster diagnostic standard was 69.7% in September. That's fractionally below our checkpoint, which was 70%, but it's still within the model range, and we would continue, depending on the impact of IA, of course, to be confident in meeting that goal at the end of the year. And on diagnostics, our published stats show we're delivering record diagnostic activity above pre-pandemic levels and above the comparable point in any previous year. So against that background of performance improving or at least holding steady in critical areas, particularly when we look at last year, on the 8th of November, we wrote to systems clarifying the areas of focus for the rest of the year that was supported by the 800 million of additional funding that was provided to partly respond to the financial and operational challenges that had already been caused by IA this year. Systems worked within 2 weeks to revise their plans, and our finance and operations teams have worked to ensure essential goals such as reducing the number of those waiting 65 and 78 weeks or more for treatment are delivered wherever possible, while ensuring that absolute requirements such as the maintenance of UEC infrastructure and plans have been protected. We've just finished, in fact, I think the team is doing the last meeting now, reviewing those plans and agreeing delivery with systems. We're now in the first week of December, and we're already seeing serious winter pressures mounting. The data that's published this morning shows the number of patients in hospital with flu doubled in the space of a week. Norovirus cases are continuing to rise, and they're up 15% on the week before, and RSV cases are also rising. They're up 11% on last year and last week. I'm sure everybody knows somebody who's unwell at the moment, and it's likely we're going to see pressure on the NHS exacerbated as a result of that in future weeks' data. As we've all discussed, not just me, NHS staff have been preparing for winter, frankly, since the UEC plan was published in January. And we have a whole range of infrastructure improvements and investments in place across every system. For example, we have more call handlers in NHS 111 and 999 services, and we've increased the number of beds. So every month through this winter, there will be more beds available than there were at the same time last year. So given this planning and the replan that we, as I said, literally are just completing right now, as everybody's already referenced, it was incredibly disappointing news to hear that the junior doctors will be on strike in the run-up to Christmas and after Christmas. It's a major escalation, and it is, as Richard said, the worst possible time of the year for this to happen. And we are worried about the impact on services and patients, particularly at this busy time. We are already planning. We've heard about some of the clinical planning that's happening to mitigate the risk to patients as far as possible. And we know systems, we had calls with the regions yesterday, are already doing a lot of this planning. But we will be writing out shortly, either today or tomorrow, from our EPRR team to lay out for systems the areas of focus, what the data that we need back from them, so that we can make sure and assure plans, but so that they have all the available data and we have all the available data to know where risk is likely to occur over this period. What we are asking people to prioritise will be the kind of maintenance activities that always take place over Christmas, and think about each week for the next 5 weeks as having an obvious area of focus, particularly next week, for example, making sure that any urgent appointments are scheduled in the only week we've got now, which doesn't have any industrial action in it. And equally the week between Christmas and New Year, which doesn't have industrial action, it making sure that as far as possible services can catch up in those weeks. The priority needs to be urgent and emergency care, including critical care, neonatal care and maternity services, as Ruth has mentioned. We know that strikes mean some appointments and procedures are going to need to be rescheduled, and we will only reschedule appointments and procedures where necessary. Systems will try to rebook immediately where possible, but of course it may not always be possible. It's important to recognise the impacts not just on routine care, but it affects issues like discharging patients, which is critical to keep the flow into A&E and out of the hospital at the other end. And there is a huge admin burden, which Julian and others have referenced, in terms of setting up and standing down work, as well as the financial pressure that generates. So the major focus has to be working with all our systems to do everything we can to protect patient safety. There's no doubt it will be very difficult. It'll put load on large numbers of roles across the NHS. We've already made reference lists of those in this discussion. I think importantly, with all the systems, is making the decisions in line with clinical judgment and making sure clinical colleagues have the space they need to make those decisions. I feel like we've probably, Aidan, had some of the conversation we were going to have now. I don't know if you want to come in again.
Yeah, no, I think we have covered that. Flow is, of course, critically important, and where there is risk across the system, we've got to make sure that's balanced in the best possible way for patients. So that will sometimes mean perhaps earlier discharge for patients in order to maintain that flow at the front door where we've got critically ill people, and in order for them to be able to come through into the system to receive care. And those, I recognise those conversations are difficult and uncomfortable, but they need to be had.
Thank you.
Thank you. Any comments, questions, reflections for Emily on ops? Andrew?
So there's a hell of a lot going on, and it's fantastic stuff, and I pay tribute to the enormous effort that's gone into getting Category 2 improvement. Really fantastic. I'm just thinking in terms of the strike action going forward, and whether or not we've empowered our local systems to really push the comms in promoting the alternatives to A&E, because I think we've still got a lot of patients pitching up in an A&E setting who don't need to be there. They could be directed to alternatives. And I think given that it's going to be a really difficult kind of Christmas, New Year period, whether we could have a concerted effort locally on local radio or the media just to make that point.
Yeah, we've worked with local systems on that, and local systems are usually very effective at particularly working with local radio, as you say, Andrew, which is a really good way of reaching local communities. So when a particular A&E is getting into difficulty, they often will send a message out. I think it's really important those messages are in balance, though, because we do have evidence from previous strike in particular that people will just not go at all. So what we want is, as Aidan and others have said, if you need A&E, you need to go to A&E. But we need, as you say, to make sure people are aware of, given the need that they've got, where should they go at the same time.
Any other? Yes, sorry, Mary.
I think on this one, as it's kind of in the lead up to Christmas, we know that for some people, mental health problems are exacerbated, sometimes associated with loneliness. So anything we can get ICBs to do to encourage hubs, as we did last winter in things like church halls and and libraries, actually. I think we could really alert how important it would be to do it from the 20th rather than the 23rd.
Yeah, thank you. It's something we'll pick up with ICBs.
Where do we think, because I know that, Emily, you and with Julian and colleagues, I mean, you've met in the last several weeks with all of the 42 systems. and have formed an assessment, clearly not just of just the financial pressures, but of actually the operational pressures, and without sort of getting into the details of which ones, but to what extent do you think we are able to help those that are most challenged, and what are we doing? And then there's a separate thought just on discharge into social care. I know that either via the Better Care Fund and then with local authorities, I know with the government has very helpfully given further funding, I think 40 million or so, available to be tailored to those via the relevant authorities into the systems which have seen most challenge in getting discharge. And your comment on that would be helpful.
Thank you. So the additional funding that's been provided over last winter and into this winter for social care, but in particular the more joint working in every system between NHS staff and care staff has resulted in better flow. It's very hard to quantify exactly what impact it's had, but we know from feedback on the ground, from the discharge hubs, for example, that I visited, that that's an incredibly effective way of doing things. There is always more that needs to be done, and there are some places where local authorities are under financial pressure, where it's been harder to deliver that over the last few months than it was last winter, for example, but everybody locally is always incredibly strongly committed to making that happen. In terms of your first question, my take on it's perhaps been helpful coming back. I've been back just 6 weeks now, I think, and going straight into these meetings with every system, is that compared to where everybody was last year, every system is in a better place than it was last year. And the tailored and incredibly high energy and focus support that's been provided to those systems that were in Tier 1 on the UEC programme has...
Tier 1 being our most challenged.
Being our most challenged systems has absolutely resulted in major improvements in those systems. But if we look at the spread of performance last winter, if we move everybody up, that still leaves some systems who are definitely in a better position, but it's still fragile. So as we saw in London over last weekend, where response times deteriorated due to an enormous increase in volume of calls and attendances, it did result in performance slipping in a way that I know the London team absolutely didn't want to happen. The system was able to recover, though, more quickly than it would have done last winter. That in a system which is more fragile to start off with, both has a more negative impact and is harder to recover from. So what we're focused on is we know the systems that are going to have the hardest time, and focusing on helping them put in place the operational improvements that we know work. So we've seen tremendous improvements, for example, of people adopting minimal waiting times for ambulances. Norfolk and Norwich, for example, has in the last 3 weeks seen a dramatic improvement in performance through putting in place better flow procedures through A&E and into the hospital. Trusts adopting the North Bristol model of moving people through the hospital, etc. We know stuff works, but it's going to take every day, every week, hand-to-hand attention to particular systems to keep everything working at this pace. And obviously the IA pressure then just makes that closer to the edge and more challenging.
So that picture you just painted of sort of London, and so it's hit by a surge.
Yes.
It can't deal with the surge and hold to levels, but actually it recovered faster than we did last year. Is that your...
I think it's not fair to say it didn't hold to level. It wasn't able to deliver the performance we'd want of sub 30 minutes, so it hit longer wait times, but it recovered within a 48-hour period back to performance that we would be expecting.
Okay.
And we were able to spot, because everybody at the system level and at the national level, we have much better data and much more immediate data, so that we can spot the problem and provide the support that the systems need, or the system can address its own challenges.
Okay. Any other... I'm going to ask Julian a very unfair question. It's sort of like a Christmas cracker question, a quiz, slightly lifting the mood. We refer to 12 gambling centres. And it's probably not one for now, but who pays for those? I mean, the gambling industry makes an absolute... Who pays for the gambling centres that provide support to patients when they have real gambling problems? Do you know that? Is that a fair question, Finance Director?
Rather than me answer, I think the answer is, but actually get it wrong, I'll come back and I will confirm that the funding arrangements are in place. And the support we do get, I think, including from industry in support.
Do we? there is some levy on the industry, but whether it's enough to cover actually the level of care that we then have to provide to their customers. Anyway, I'm getting outside policy, aren't I? So we'll have to...
Richard, if I may, I do, in these conversations, we often have a focus on acute care and primary care. And I do wonder at a future meeting whether we might spend a bit more time on mental health. I've made reference to people who might be on sections who might not get the attention they require during the junior doctor's action. And I do think it is worth us spending some time on that. I was also fascinated by the increase in numbers of people with autism in hospital. And I thought, I don't quite understand what might be going on there. And I do understand what we've been trying to do in terms of caring for people as often as possible in the community as opposed to in long stay or in hospital. But I just wonder whether there might be some merit in us
doing a real deep dive.
More time on those kind of issues.
Simon, you would presumably absolutely agree with that?
Yeah, I do, yeah, we should. I mean, we're overwhelmed now with referrals for autism and ADHD assessments, and the waiting list is dramatically increasing almost on a monthly basis, and we're not managing that at all.
I mean, I try and carry these stats in my head, but you'll correct me. So we had a 39% increase in children and young people's presentations of mental health conditions in 22. And I think it's 25% of 17 to 19-year-olds we now believe have a...
But you're much more accurate than I am, yeah.
Well, I suspect I'm not, Simon. I've got
up again another 50%.
But it was one in 10 17 to 19-year-olds were presenting with some mental health condition in 2017, and it's now 1 in 4.
There's two separate things going on there. One is the actual prevalence of disorders, which has gone up in children and young people, mainly young women, 16 to 24, gone up around 6 to 7%, which is actually very big in population terms. The other is people coming forward, which has dramatically increased, and they're very different things, including in adults as well with neurodiversity or ADHD, when the prevalence hasn't changed, but the criteria have changed.
I think it's well worth, as you say, David, a deep dive. So can I move us on to financial performance, having given Julian an easy first question on gambling centres? Julian, the financial position, 7 months, 7?
So just by way of context, let's remind that earlier at the beginning of last month, about a month ago, as we described at the beginning, we have injected £800 million of new funding into systems and have reduced the sort of elective activity threshold we expect people to do before we will top them up with extra income. Those two steps effectively cover the cost, the impact, or the financial impact, not the activity impact, but the financial impact of strikes up to the end of October. Right. As a result, when you play through the impact of that and the flexibility that people are using, to cover what I'll come on to, which is some of the kind of underlying inflation pressures that also exist, the table in the paper shows that the overspend against plan up to the end of October is £400 million, and people will note that is a lot less than it was in the report we shared last month, and that is because we have now effectively covered the cost of industrial action. That still shows the degree to which people are behind plan as we went through month 7. That is roughly equivalent to probably where we were. In fact, probably last year we were a bit further off. However, one of the reasons for that position is that we are still dealing with much higher inflation. So the data published by the OBR and the government in the budget, not the budget, in the autumn statement, showed that we outturned on the GDP deflator measure, we outturned 22-23 at 6.7% inflation. Now, just remembering 12 months ago, the forecast for the end of 22-23 was 4.4. So it's about 1.5 to 2 percentage points higher. And currently, the forecast for this year on the same measure is 6.1 That is about 4 percentage points higher than the forecast last autumn, and the basis on which we were funded and budgeted for the NHS. And those two things combine to create sort of a recurrent unfunded pressure of about £1.7 billion, which we are dealing with, and we will have to deal with on a recurrent basis as we then look forward to 24, 25. I mean, that is a really significant cost. That is just the non-pay inflation cost. And we see it, as I've described in previous board meetings, in medicines prices, continuing healthcare costs, and just the kind of basic contractual service costs that our organisations are facing, PFI costs, energy bills. Now, it's worth just putting it in context. When you look at those inflation figures, and I think the IFS, the King's Fund and others have made these points, it means that the average real terms growth in NHS funding from 2019-20 to 2024-25, before you look at whatever the outcome is of the consultant pay deals and things like that, is for average real terms funding will grow by just over 2% a year in real terms. So over that 5-year period, when we set off on the long-term plan, we thought the funding would be at 3.5% real, so it's just over 2% real. That's roughly the same as NHS funding growth the years 2015-16 to 2018-19. And in the middle of that, we've clearly had to deal with the pandemic and with now the recovery from the pandemic, which I think just shows why the performance pressures on the ground, when you look at the funding and the operating conditions, industrial action this year are as hard as they are, even with the improvements that we have made. I mean, that translates into, effectively, we absorbed a 4% close on a 4% real terms cut in 22-23, flat real funding this year, and it looks like it'll be, slightly better than flat real next if the inflation forecast holds good. So just worth having that as context. Clearly, we are doing we've asked every system now to reforecast its position. We are pulling all of that together. That will still show that we have a pressure that we have to deal with. It doesn't just immediately turn around and reflects, some of that underlying inflation pressure, which we are taking steps to manage. But those steps in local systems include money we had intended for improvement and transformation of certain services is inevitably going just to cover some of that kind of basic cost pressure. And December and January strikes will clearly put further financial pressure as well as service pressure, which we will be in discussion with the department and government as to how we deal with that over the next days and weeks. But that's where we are. Notwithstanding the impact of the strikes to come, we're still forecasting, therefore, to live within the funding we have been given, except for, as I said, whatever is the final result of any further pay settlements, for example, if the consultants accept the deal that has been put on offer. So all of that being worked through.
Questions or comments? So Jeremy and then Wal.
Yeah, Julian, clearly a lot of pressure and some very tight short-term pressure. I just wonder over time where you see the opportunity for productivity to play to help relieve, maybe not now, but in the future, whether there's a role for technology in helping with that, and if there is, how do we create the capacity for investing in technology when the current pressures are so tight?
I mean, we think technology has a massive role to play, both in the sense of how do you create better, more efficient, standardized processes through it? How can you create better communication with patients? How can you put more of the responsibility, actually give patients the tools directly for care rather than always having to have a face-to-face interaction? The join up of data, we talked about the commitment and investment we have just made for the NHS. I think the sort of generative AI large language models have the ability to transform, actually, I would say, how much time we've got individuals spending on admin. I suspect that will be actually one of the biggest transformative things we can do. A lot to learn how that gets applied and how we do it safely and all the rest of it. And despite the pressure, we are keeping going with what we think are the foundational investments to make that possible. We are still rolling out sort of EPRs in the frontline digitisation programme. We will still progress with the sort of investment in data and joining up the data and the applications that make that useful. We are still investing in the NHS app. We will need to see the pace at which we can keep going, but it remains a priority for us.
Well,
thanks, Richard. So, Julian, you're painting quite a bleak picture. I mean, one which has been, as you say, tough picture in terms of people on the ground finding it very, 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 very difficult. And that's this year. In the private sector, we've been experiencing this. We've been responding in much the same way as you have in the NHS. But we look to next year and we sort of go, gosh, that doesn't look... you'd be quite hard-pressed to bet it's going to get materially better economically in terms of inflation and interest rates and what have you. How are you thinking about that? And what sort of message can we give to the system about next year, which is not that far away?
Well, look, we are working on, how we finalise budget allocations, baseline budget allocations for systems and the kind of rules, the framework within which we're going to be asking them with the government's agreement to work as we look at next year. Those conversations are ongoing. We have put investment in this year to increasing capacity, and the baseline is let's maintain that capacity into next year as we continue our recovery from COVID. And I just think we all need to recognise you don't recover from the shock that we, had overnight. That takes time. We can see it's happening. Notwithstanding strikes, we're doing more work this year than we did last. We can see improvements in productivity measures. The fact that sickness absence is coming down, that has been a major hit to what we can achieve. The fact that retention has improved this year, not as much as you always want, but that is improving. So we just need to keep going with the journey of recovery, and with the resources that the government agrees to give us, just do the absolute best that we can for staff, patients and taxpayers.
Any other comments? Sorry, Mary.
Just one. The last section of your report is on the capital expenditure, but listening to your eloquent description of inflation, do you see a problem there as things that have been started or are due to start will cost more than originally anticipated?
We are definitely seeing, in particular in the construction industry, we've definitely seen the price of basic materials go up. That does mean that some of the programs we have started are costing more. We are seeing that in some of the kind of big hospital rebuilds that are already underway. In fact, even those that sort of have come to or are close to completion, and some of the other transformation schemes, and we're having to deal with that. Clearly, again, for every pound you spend, it just means it goes less far, so it does squeeze our ability to do other things. That's just it's a fact that we are dealing with.
Thank you.
Julian, thank you very much. It is a tough position. We should expect it to be a tough position. We also see it in the private sector, it's a tough position. Inflation, which has sort of lain quiet for so long, is not quiet, and everywhere people are having to deal with that and thinking how to manage their businesses or their operations in the teeth of it. There is actually, isn't there? We're going to see some small additional costs coming through from actually what was very good, which was actually the agreement on VPAG as was, and now VPAS, I think. And that will have, a couple of $100 million knock on into this year or something?
Our forecast for 24-25 is that creates a baseline pressure of about £250,000 relative to the scheme we have been operating up which we are operating up until the end of December 2023.
But it was good to see that agreement between government and the industry.
It is really good to have agreement. It's really good to know how we are going to work together and to create the basis for, continuing to work on improving the approach to research, clinical trials, as well as for the ability for the NHS to access groundbreaking treatments.
Very good. Let's move on. I think we're going to item 5 on the agenda, which is, Alex, I think, it's a primary care access recovery plan, and it's an update really on delivery. So, Alex, you have the microphone.
Thank you very much. Thank you, Chair. Good afternoon, everyone. So I'd just like to take you through the paper that we've got presented to the board today on the delivery plan for recovering access to primary care. You will recall this publication in May, and Amanda Doyle gave the update just a few days later to the May board. And just as a reminder, the plan at the time was well received, had good support at publication, and we're now 6 months into this 2-year programme. We're continuing to have good support for the plan, and a significant progress has been made in the first 6 months of the programme of work. I would just highlight, although Richard has highlighted this as well, that it's a challenging backdrop. So primary care, much like the rest of the NHS, is under significant pressure. But I would just really point to the capacity and the workload that is happening through primary care and general practice at the moment. More than 1 million appointments every day, as Richard highlighted, in general practice. The paper itself reminds the board about the fit of the plan into the broader context. It references the fuller stock take. But I would say, just again as a reminder, this plan is unashamedly about improving access to benefits patients and staff. It doesn't cover those broader parts of primary care. Its overarching ambition really precisely around access, tackling the 8 o'clock rush and making it easier and quicker for patients to get the help that they need. We have 4 key areas in the plan itself. For each of these areas and their associated commitments, we've got a very clear programme of work in place with governance and across NHS England into ICBs and out to frontline services as well. And the board sets out the progress in each of those 4 different areas. So if I may, I'll just pull out a few of the key points in each of those. So firstly, in relation to the first area, empowering patients, just to, reiterate some of the earlier points, we've made some really good progress with the NHS app. So we've already achieved some of those ambitions, and we're on track for 90% of practices to enable prospective records access by March 2024. This has a big impact, both in terms of the convenience for patients, but also in terms of the efficiency and effectiveness for practices as well.
Can I just pause you just a moment, because I just want to make a point again, because I think we rather glibly talk about, people rather glibly talk about the NHS app. It didn't exist 6 or 7 years ago.
Yeah.
It is utterly remarkable and transformational for the way patients are able to access their primary care services. And the more we invest in its functionality and increase its functionality and improve its ability to cross between primary and secondary, so much better will be our ability to engage with patients and give them the service that they need. And I just think we just sometimes it's sort of in the background. It's the NHS app, but actually it's transformational, and it's 6 or 7 years old. Anyway, sorry to interrupt.
No, thank you. No, absolutely. I imagine that every one of us around this table has got it on their phone right now. Yeah. So just to go back to the empowering patients, secondary and a good segue actually around NHS app is around the self-referral part of the plan. So we committed to expand self-referral services by September, and by September we had over 600 services offering those self-referral routes. That's continuing to progress. We have, I think, really excitingly started to see a real shift in relation to expanding community pharmacy services, recognising the role as community pharmacy as a clinical service. So at the beginning of this month, we met our ambition to expand blood pressure monitoring and also introduce direct prescribing of oral contraception, expanding that service. We're now focusing in the community pharmacy world on launching the pharmacy first service at the end of January, which will enable pharmacists to supply prescription-only medicines for 7 common conditions. Key focus for the team at the moment is working particularly with digital suppliers, recognising the digital complexity of the programme and connecting community pharmacy and general practice. And in pharmacy, we will also be supporting that with a public campaign in the spring to really try to emphasise and explain to the public the sort of clinical services that they can expect to receive in community pharmacy. The second area of the plan related to implementing modern general practice. And again, we've talked a bit about this in the board already around the role of digital technology. In implementing modern general practice, we're making real progress on digital technology, but also on practice transformation, both in terms of support to practices and training for staff as well. For the digital world, our focus at the moment is on digital telephony. So we have now around 83% of practices with digital telephony in use, and we're working with ICBs to ensure we have that in place across all practices by March.
And that digital telephony allows, essentially it's multiple calls, it allows callback functionality, it queues appropriately, is that what it does?
Precisely. And so, and it means that we won't know patients will hear an engaged tone anymore, which is a kind of, key. So, all of those points, callback, particularly helpful. Linked to that, there's also a digital procurement framework, which is just going through at the moment. We aim to have that launched at the end of January, and that will enable practices to draw down from the procurement framework for some really high quality online consultation, messaging and booking as well to, really improve the experience of both patients and staff. We have had good uptake of care navigation, a key part of the plan to train staff to be able to help patients get to the right part of general practice. So good uptake from staff. And similarly, in relation to practices themselves, we have over 1,200 now going through the General Practice Improvement Programme. The two final areas of the plan, building capacity, there are two kind of key elements to this. So firstly, around additional staff, and we have met the ambition around additional direct patient care roles with 31,000 additional roles in place. We've been running a public campaign since October to explain the new roles in general practice to the public. And the second part of building capacity has been around additional appointments, and we're confident on delivery of the 50 million more appointments by March. The final area I just wanted to draw out is cutting bureaucracy. We've made good progress on that, but a really key focus to draw the board's attention to is the primary-secondary care interface. ICBs have been reporting on their progress to their boards over the autumn, and we're just in the process of reviewing that. But the opportunity to improve how general practice and primary care and how secondary care work together, improve the care pathways and become more effective across the two areas is going to be really important. And Claire Fuller, who spearheaded the Fuller report, joined by Dr. Stella Vig, will be working across ICBs on behalf of NHS England on this. Finally, just today we've announced as well the commitment for online patient registration has been met. So we now have over 2,000 practices using the service, which means that people are able to more easily register with the practice. So I think in summary, you'll see in the plan good progress to date. Really pleased how well supported the plan remains and our progress on the key milestones. We appreciate that the upcoming milestones aren't without risk. There'll be a lot of work for us to do, but we'll continue our focus on that. But I think really importantly, we're really beginning to hear now about how access and experience is improving. So as we go forward, we'll really want to understand and measure some of the benefits and impact that the programme's having once we've got some of the infrastructure into place. And finally, I think it's just probably worth saying thank you to teams across NHS England and the ICBs, and particularly to primary care, general practice and community pharmacy, who have really pulled out all the stops to get us as far as we've got so far. So 6 months in, we've got a lot to be proud of.
So Alex, I'm going to open it up for questions or comments in a moment. I mean, I thank you for a very clear presentation and a very, very good paper. And you brought it to life very well. I think there is clear benefit from the focus that has been on this this work on access. It's very strong and real work on access, partnering, as you say, with community pharmacy, but also actually with primary care. I sort of reiterate what I said at the start, actually, that primary care is doing 17%, is my belief, more appointments than it did pre the pandemic, which is a remarkable lift. And again, we often lose sight of just the huge value of the contribution, not just by our GPs, but by practice nurses and physios and prescribers and social prescribers, etc., who function in primary care for us. I did want to make a comment, which is going to sound rather jarring, not to us, but I was irritated to read the representation, I call it the misrepresentation, of a study which was published by Oxford, some elements within actually my old university, so Oxford University, around actually virtual appointments. And the headlines on front pages it was given, I don't mind it, it's rather jarring, but actually rather helpfully a very capable journalist who read the report in detail did actually draw out that actually what the study said was an important overall finding from this study is that examples of death or serious harm associated with remote encounters in primary care were extremely rare. And that's not actually how it was portrayed in the media. And I don't mind sounding rather jarring, but sometimes there is a portrayal of what primary care does and the way it's provided to patients, which is just wrong. My own personal experience, when I'm called in for my annual blood test and then I'm offered a phone call by my practice to go through the results of my blood test, that's brilliant. I don't need to go back in to sit in front of the person to actually go through the list of the outcomes. So I think... Actually, I just wanted to make that jarring point, but anyway, there we go. At which point, I'm going to open it up for comments or questions. So Munir, then Andrew, then Wal. Munir.
Thanks very much. Good to see all the progress. So I've got two questions. The first is about blood pressure monitoring. It's great to see that this is getting started. I run a blood pressure clinic in secondary care. So there are a lot of people out there who are wandering around with high blood pressure who don't know it, so it's important we identify them and it's easy to treat. I'm just wondering what happens next when the blood pressure is found to be high. It doesn't necessarily mean that they've got hypertension. They presumably have to be referred back to the GP who has to do an assessment. So can you just comment on the capacity and access in terms of the GP then being able to look after that? And the second question is on pharmacy first and treating conditions such as sinusitis, etc. How are we going to make sure that there is not overuse of antibiotics given the dangers of antimicrobial resistance?
So Alex, what we're going to do, we're going to just take a couple more if you can sort of scribble down what they are. So Andrew?
So my point was in relation to capacity. So we've got another 31,000 people working in general practice. What was the criteria for allocating those individuals, in the sense of, was it focused on poor performing general practice surgeries, or was it deprived areas, or was it just an even kind of spread of increase?
And if we can take one more before you deal with those, Alex.
So very quickly, one question was on, you'd mentioned in implementing modern general practice access, a lot about technology, etc., and interface with secondary care, but you didn't talk much about social care. because that's the other place where easing and the GP's access and understanding of what's going on. And there's a lot of people providing digital care records now for that whole area. And the second part of my question was on cutting bureaucracy. This is slightly unfair because you seem to have done quite a good job already. You're pleased with the progress. And what next? Because there's always more to do. And just because you solve this bit, actually, you need to look at the next wave of things that need to get going. So if you could just give a flavour for that as well. Thank you.
Do you want to have a go at those?
Yes, thank you. I might go in reverse order on some of them. Cutting bureaucracy, that's a really important point about what next. I think it's fair to say, and I'm sure the clinicians in the room would agree, that there is a huge amount more to do on primary-secondary care interface. I think we're starting to scratch the surface, but I think that is an area where we will really need to have a concerted effort. So I don't think that will be solved immediately, and it will be really interesting to see what the ICB plans say in terms of progress so far. In relation to social care, a really helpful point. Clearly, as part of the teams that work in practices, we've got more social prescribing, and some of this I think links to Claire Fuller's work earlier as well around what the integrated neighbourhood teams look like and how you have a community around people who are serving them that are made up of the totality. So again, I think, for the access recovery plan, it is focused on access, but there are those opportunities, and we should make the most particularly of some of the roles in general practice. The social prescribing link workers would be a good one. In relation to the additional roles, so we've had an additional role reimbursement scheme that's been running now for a number of years through the GP contract. So practices have been able to draw down from, as part of the contract, and appointing people firstly in accordance to a list of professionals that have been available. And I will check out precisely how they were identified in the first place, and particularly your point about health inequalities. In relation to Pharmacy First, that point about antimicrobial resistance has been a really, really important part of the programme of work. I know Steve, particularly, been very involved with it over the last 3-4 months, along with Chris Whitty, to make sure that we are in a good position. And part of the thing that we've really needed to look at is to really take into account how do we make sure that we monitor well the prescribing rates and that they are within tolerances, which then I think finally relates back to the blood pressure monitoring. For the blood pressure monitoring area, and indeed all of the community pharmacy areas, it's been important to be able to make sure that we've got good technology linking up primary care general practice and primary care community pharmacy to make sure that where action needs to be taken it is, and that it can be done in a non-bureaucratic way as well, to make sure that we are able to treat patients when they need it.
So can I just ask, it's the sort of the mind your eye comment in paragraph 7 about Pharmacy First. So Pharmacy First is a brilliant idea. And a really good engagement. But it's that last sort of couple of sentences, delivery remains challenging due to the changes needed in digital infrastructure, and we're working with suppliers, support January's implementation. Confidence that we're getting that sorted out, or is it likely to be delayed? I mean, what's the essence of the problem?
So the essence of the problem is the complexity of connecting digital suppliers in general practice and digital suppliers in community pharmacy, because we've never done that before. John may want to comment as well, but the team are tracking this on a day-to-day basis, with delivery confidence being looked at on a day-to-day basis as well. At the moment, their focus is on testing on first of type and some of the consultation readout areas particularly. So I think on this one, we will need to continue to monitor and be clear about the impact of the progress that they're making and the position at the end of January.
John, is it something you can comment on, or?
Just to underline the point, it's a complex environment, multiple suppliers, and a fixed timescale. So I think it's right to be cautious about the delivery. Everyone is doing everything they can with daily calls and holding suppliers to account, and so we're monitoring it really closely.
Okay, thank you. Are there any other comments or reflections for Alex? Really good. Thank you very much, Alex. Excellent. Thank you. So let's move on. I think it's item 6. It's Naveen, a long-term workforce plan update, and this is a really, really important step forward for the NHS. So.
Thank you, Richard. So it's 5 months since the publication of the plan. So I've brought this update to give the board a sense of the work that's been going on. We've picked some of the key pieces of work. There's actually a lot going on, so this would have been a very long report. But we've kept it to what we feel is really important for the board to recognise at this stage. So I'm going to just pick on a few areas that I want to describe by way of introduction. First of all, in November, we hosted the first long-term workforce plan delivery summit, where we brought together many stakeholders to work together to implement the plan, to consider how we would do that, what are the challenges, how are we going to work together to overcome them. We had representation from around 100 organisations, and it was a really good day. People stayed right to the end, which I think is always a good sign. And they were sharing what were the thorny issues, what was already working, where did we need to work together to deliver as a coalition in the main areas of train, retain and reform. And we were able to think about now and also hold on to what we needed to do for the future. One of the overarching themes we heard on the day repeatedly was how this plan gives people hope. And that was a really important, a precious thing for us to hold on to. And it was really an opportunity to think how collectively we could work to deliver a sustainable workforce and really hold on to the concept of more and different, which is central to the plan. So we started to work on, as we move into early stages of delivery, how we galvanise the service, how we galvanise all of our partners across government, in education, in our professional bodies, with our regulators, there's a very long list, to actually do this work together. But we can't, each part can't do it on its own. And I think that's a very important message. So there will be further events in the coming months. We are going to have 3 planned where we are breaking down the work in those areas. And so I'll be able to report back to the board on our progress. In the meantime, progress is reported to the Workforce Training and Education Committee of the board. So I just want to pick on a couple of areas, if I may. In train, we actually brought forward delivery of 205 additional medical school places this year. That was not part of the original plan, but we did that because we thought we could and government wanted us to try. So those places are to be shared across 5 medical schools, and we made sure they were in the areas or areas of need in accordance with how the spirit of the plan. So that adds 205 places to the addition to the existing 7,500. Another point to make is 1,106 students were recruited to our blended learning pilots in nursing to date, and those blended learning pilots are really important to help us inform and plan for how we learn in the future. And we've already mentioned retention, and we are very cautiously proud of the work that is being done out there in the service, not here in NHS England, but out there by our leaders and our staff in the service to really tackle retention and not have our new staff just replacing people who are leaving. So that's a really important point. So the staff leaver rate is down for the 12th consecutive month in August. This means that there are about 14,000 people who have stayed in their roles in the NHS. The People Promise Exemplar programme, we've seen really great improvement where we've tackled the leaver rate, and so now we are rolling out that programme further. we've had more trusts wanting to be part of that programme. We've already mentioned the 50k nursing target that was achieved, which was a manifesto commitment through training, through recruitment, and through retention. So all parts working really well together. In fact, we exceeded the 50,000. In reform, I just want to mention two areas: enhancing generalism, which is something that is really important that we think through very carefully. So we've got 7 regional trailblazers piloting the new model for generalist skills training for postgraduate foundation and core psychiatry, and that's what we're targeting at the moment. So we'll begin to see what the results of that looks like, what we're learning from it, and how we want to spread generalism training and understanding. So can I just also go into one area which is hot off the press, which is the rise in acceptance on medicine, dentistry and midwifery courses, because we had some information from UCAS. The data published today, in fact, from UCAS shows that the number of students accepting places on medicine, dental and midwifery courses has risen over last year, but we actually want to get more applications in, and then we want to convert those applications into acceptance. And so we're doing some very detailed work with the university and higher education sector, because we've got another opportunity in January to have a look at how we're doing and then do further recruitment drives for students. And they have to be really done locally, as well as with our national campaigns. So that is another area of target for us going forward. I think I'll stop there. I could go on.
It's very good, and thank you for your leadership in this space. Actually, it's really important. And as I say, thank you for your leadership and for the progress that's clearly being made. I might get David to comment in a moment, because David and I went up to Lancashire and South Cumbria actually 3 weeks or so ago on a visit, and actually we had very good interaction and conversations about actually how do you scale up training and particularly it's less, this is my layperson's view, so it's going to be wrong, it's not so much the opening of the places, it's actually then giving a practical experience and training placed in the system as our nurses, training nurses and doctors go through that initial education. It was a really very good visit and very informative. I might get David to comment in a moment, but comments or questions to Ruth?
Just to build on what Naveen has said, of course we did meet the 50,000 nurse target 6 months early, and as Naveen has said, domestic supply, retention and of course international recruitment was part of it, so 93% of that target was achieved by international recruitment.
I know.
So it does show the need to have the long-term plan so that we can rebalance domestic and international supply.
Yep.
Very good. Other comments? Yes, I will.
Is it worth just commenting a little bit, Navina, on the university partners, who are obviously very key delivery partners in this? There's a lot of noise in the press, and you know, I'm entirely sure you're on it, and I would just love to hear more.
Yeah, so we work very closely with Universities UK, Office for Students, Medical School Council, Council of Deans, and then at the regional and ICB local level, there are really strong partnerships between our trusts as placement providers and higher and further education. So at all of those levels, we've got a long history of strong working relationships. We also have a long history of solving problems when they arise, and they do. And I think it's really important that we don't forget that. They give us feedback about placements in the NHS, and we have that when we have to tackle them, and we work with them when there are concerns about the education aspects. They are all, I could say, many of them were at the summit, and we continue to work with them. They are really keen to be part of this expansion of placement for 2025. They are really keen to be part of the delivery of the plan. They did work with us on the development of the plan. There are, of course, concerns about the capacity, the educator workforce, which is our concern, but it's also theirs in the education sector, the infrastructure, their ability to reform in terms of changes to their curriculum. So we've got a number of work streams which we work closely with them. The final thing to say is through the ministerial board, which we're part of together with cross-government, which includes the Department for Education and the Treasury on that board. So we try to identify and address issues that way.
Yeah, we're certainly working. I mean, you're working very closely with government, I think, which is really, really helpful across the relevant departments. I know Mary's made points earlier, and wholly correctly, about just making sure we also think about is not so much scaling up the number of doctors and nurses. To do that, we've got to scale up the number of educators who are going to actually provide them with that training and oversight.
So we look at our own educator workforce, but we work very closely with them and together raising the need for their educator workforce to be expansion as well.
Now, David, do you want to comment on our trip to South Cumbria and Lancashire? It was good. It was really good, I think. Really informative, instructive.
So Richard and I went up to the northwest of England and we spent some time with the senior team and the people team at Lancashire Teaching Hospital.
Yeah.
We then met the system chief executives for dinner and spoke to them about their approach to workforce planning. So that was the Acute Community and Mental Health Trust chief executives. We then spent some time with the ICB leadership about how they were approaching all their challenges, but particularly the challenge around workforce development. And then the last part of our visit was to UCLan, the University of Central Lancashire. The purpose of going to that visit is UCLan have been pretty innovative about their nurse education and their medical education. Particularly, so this is a community I was born and brought up in, how in those industrial textile communities of the northwest that have not really had replacement industry since the 80s, does UCLan provide an offer which provides different and alternative routes into education for people in those communities to enter the healthcare workforce, so apprenticeship routes, arrangements with both Lancashire Teaching Hospital, the University at Lancaster, but also some of the local trust on how they were providing curricula for operating theatre assistants, nurse associates, etc. And interestingly,
dental school was amazing.
A number of the operating theatre assistants are people that had other assistant roles and saw this as a career development, which was interesting. So I thought it provided a really fascinating picture of the connections between the employers, the commissioners, and the providers of education. And I came away with a real sense of both what they'd achieved, but also what the potential to achieve even more was in those communities. To pick up on one of the points that Navina was making, we know that part of the northwest is, in inverted commas, under-doctored, and therefore the medical school there, which was largely developed with self-funders coming in, so recruitment from abroad is now being balanced with domestic students going in as a result of the workforce. And I think the ambition really is to see how does the ICB convene both the employers and the providers of education to have an articulate conversation about what the future service provision is and what is the workforce that's required to work in those services. And then how can the university begin to provide that alongside some of the further education providers, the colleges, because the potential for partnership arrangements between was there. The last thing I'd say, Richard, thank you for the opportunity, is when I've been visiting universities, they've always said, what will the health service look like in 15 years' time, and etc. And it's also an opportunity for us to say to the universities, what will a university look like in 15 years' time? So we've just had a conversation about AI, technology, digital and development, and actually being transformative, and it will be equally transformative of the way people learn in the future. So I think these issues around blended learning need to be really featured in as part of the agenda of what is education going to look like as we go forward, and how do we then blend practice placements with the way that education is.
And you and I saw when we were showing what was simulation in terms of training of patients.
Yeah,
it's brilliant.
Very sophisticated.
Very sophisticated.
£200,000 mannequins that can pretty much do anything that any of us could do.
And better, better and faster for it.
It probably doesn't hurt as much. And then the last thing I'd say for the board is the Workforce Training and Education Committee of this board meets next week, where all the points that Navina has gone through that are referenced in the report will go through the detailed programme documentation to hopefully give the board some satisfaction that there are delivery plans that support all these commitments that are made here. And I've said this in a private meeting earlier, but any member of the board is welcome to attend that meeting and make a contribution to that work. It really is important that this is owned by the whole board, just because of just because it's important, it's owned by the.
So you chair that committee really ably with and with the support of Navina and the team and so on. But this will be a regular item. It's such an important piece of transformational reform to plan our long-term workforce and then to execute upon those on the milestones. So it will come very regularly to the board, I think. Shall we? Let's move on. Shall we go to Ming? It's Federated Data Platform update. And we did touch on it in the private board, but if I can start with my congratulations, not just to you, but to the whole team, actually, Vin and others, and Julian and others who sort of managed what was quite a lengthy and complex process, actually, to get to the announcement of a few days ago now. And I think this is like the long-term workforce plan. I think this, when we look back in a few years' time, this is a substantive step forward for the NHS in terms of its management of its technology and its data. But Ming, do you want to give us an update?
Thanks, Chair. And want to extend my thanks to Jackie's team as well.
Yeah, sorry.
We've done a huge amount of commercial work. That's a bit of a first. So really delighted to inform the board that we've awarded the Federated Data Platform and Associated Services contract to a consortium led by Palantir, including Accenture, PwC, Carnifera, and Next CSU. This is really important because it demonstrates the breadth that FDP and the associated services cover. It's not just a data platform, but actually how we then deploy and adopt it and create new products off it. In parallel, we also procured and awarded the contract for the privacy enhancing technology. And that's really important to maintain privacy of the data. And that was awarded to IQVIA as well. And we have a commitment to make sure that before we launch the new Federated Data Platform, we'll also integrate the PET technology so that all the data going into the Federated Data Platform will have passed through the privacy enhancing technology first. So those two things are first. The privacy enhancing technology will be a core service that anyone in the NHS can draw on, so it's not just linked to the FDP, but will also help us standardise the way that we de-identify data and make it available. It also becomes the technology to support data sharing as an information governance tool, which will then provide an audit trail of what the purpose of the data has been used for, where it's gone and who's actually accessed it. All really important factors for the public trust, which this programme has tried really hard to maintain. So I'll just point out that this has been a long-going project. There are some myths out there of what the programme is. What we're really trying to do is connect the NHS. None of the data sharing arrangements are changing. There's been lots of questions around whether FDP will include primary care data. Because the data sharing arrangements are not changing, if a local system in an ICS has data sharing agreements with the primary care and they're working as a collaborative system as we're intending them, then absolutely primary care data can go in. At a national level, we don't have a national feed of primary care data. So in the national use cases, it's not appropriate. In the national use cases, it's not appropriate for us to see identifiable data, and therefore the platform will separate those uses. So just wanted to reinforce that it is a piece of technology, it's a piece of software, and really it's going to help redesign processes and enable those processes. But in effect, we still have the governance processes through the privacy enhancing technology, but also the local data sharing arrangements. We're now in transition and mobilisation, so both the suppliers are now talking together to make sure that their platforms integrate. We're very confident that they've worked together elsewhere in the world, so we're very confident that will be the case. We also, during the procurement, procured a number of core capabilities, which they're now, Palantir and their suppliers are actually supporting the build of and transition of that. We have a 6-month transition period by which we'll make sure everything's working before we roll out and deploy new products. In order to bring the public alongside with us, we've done extensive engagement with the profession as well as public bodies such as National Voices, Patients Association, Royal Colleges, and I wanted to thank members of the board that really supported us in speaking particularly to the Royal Colleges and Chris's team in communications, who were a great help with the media and central support. We have set up, in our aim to be more transparent going forward, a check and challenge group with external stakeholders, and those stakeholders will help us define and support and check the use cases we want to take forward for FDP, and make sure that we're not doing anything that is not acceptable or is not in line with the way that we want to work. And that check and challenge group is actually chaired by the CEO of National Voices. So that's an independent advisory group. As part of the engagement, we'll continue to work with ICBs and also our regions and trusts. We have a target of adoption at trust so that we can actually make the best use of the applications that we've already developed during the pilot sites. And as part of that transition, our expectation is all the applications we've built so far in the pilots will be available on the single instance that we deploy to each trust and ICB. So there's quite a considerable work on how we do that. We're working through with incentives of how we can get better deployment and better adoption. And we've started lots of regional workshops with our regional colleagues as well as ICB chief execs in order to make them aware of the functionality, but more importantly, what they need to do to get ready to accept and deploy the software. I was going to leave it there, Chair.
Mike?
First of all, congratulations on getting it over the line. I think we'd all agree around this table it's a fundamental building block for re-engineering the service in the future. And also congratulations on providing the right level of reassurance in terms of how we will look after and handle people's data in the future. I just wondered if you comment on the corollary of that, which is what is the impact on our ability to care for people who choose to opt out of data sharing, because clearly that's a potential issue in the future. So I'd just be interested to hear your views on what that could mean in terms of our ability to support them in the future.
As part of this work and as part of, sorry, my voice is going, a part of the data strategy programme, we've started a large-scale patient engagement narrative and also lots of workshops, etc. So as part of that, we're actually checking in what the views of opt-out. With the joint data privacy policy unit, we're also re-looking at what does opt-out mean and how do we really make sure that's aligned and understood by patients. I would say that we're tracking opt-out quite well, and at the moment we saw a slight peak when the announcement was made, when there was quite a lot of social media by Foxglove and other privacy campaigners. But the opt-out level has not really materialised as much as we feared. We've also done quite a lot of work with our frequently asked questions so that they're public-facing, and have tested that with our external stakeholder groups so that they've helped us shape the messages so that people can actually understand that for direct care, they don't, it's not in their interest to opt out. Obviously they can, but it's unlikely. For secondary use, once we explain what we want to do, patients have been very supportive. And actually, I think there's a wider narrative around, I was at Our Future Health the other day. People actually want to contribute their health data for the NHS to do more research and actually to improve services. So I think there are quite a lot of important voices that we need to raise as part of that deliberative that we will do with the public. And I think putting in place the controls and the transparency of who's using your data for what purpose will support that. We're doing some work with a couple of organisations to look at what a data donation metaverse would look like so that we can actually visualise it for the public to make it more, to bring it to life. Otherwise it's quite a difficult concept to grasp.
So I think we'll probably touch on Federated Data Platform in future meetings in the CEO's report, unless we get substantive success or other or material challenge to it. And otherwise, I think we'll continue to monitor it in the DDAT committee. But what I think, from my perspective, is really important is that we incentivise the right take-up from across all of the trusts and all of the systems. This has an ability to synthesise nationally the data across England's trust secondary system. You can capture primary, but it's a different type of interaction. So it's really important we incentivise that and get the FDP to be that single national synthesised system, actually. And for me, that would be a really, really important step forward. David?
Richard, thank you. Ming, again, congratulations. I'm fascinated by paragraph 11 in your report, where you talk about the existing tools to focus on priority areas such as care coordination, virtual wards and optimising discharge. Richard, just to pick up on your point about looking forward, I wonder whether we could have some of those stories, because in a sense it took me ages to get what this meant, and actually if we could just make it live about how those pilot trusts have optimised improvements in discharge, for instance, or in care coordination, then I think it would really punch its weight and, as Mike said, be the transformative tool that we want it to be. And I just wondered, now the procurement's done, I'd just really encourage us to think about telling this through stories of real life improvements that have...
We do on our website, we do have case studies from those sites that have already been piloting, and there are some videos on there, but very happy to bring back to the board.
Yeah, because I think what it would do is, I think the consent point that Mike was exploring with you about confidentiality, etc., if people saw that's the use it's being put to, I think you'd get a bigger buy-in quite
yes.
Very good. So, Ming, thank you. And Jackie, thank you. I forgot, thank you to you and your team, as I did observe the intensity of the discussions and the negotiations, both with the third-party consortium providers, but also working it through the various government departments where we needed clearly to get support and approval. So thank you very much for all of that. Let's go on, if we can, to the last sort of substantive item for discussion. There is an item under governance and assurance, which is for noting. But John Stewart, welcome. I think John's going to lead Julian on this, I think is right. So Director of Specialised Commissioning, John Stewart. Next steps with regard to delegation down to the Integrated Care Board, the ICBs.
Thank you, Chair. Right, so the board has previously been cited and supportive of our plans for delegating commissioning responsibility for suitable specialised services to integrated care boards, really in order to support both a population health management approach across whole pathways of care and to help tackle health inequalities in terms of access to, quality of and outcomes from specialised services. Now, just as a reminder, NHS England is the accountable commissioner for a diverse portfolio of roughly 150 specialised services. And over the last decade, we have taken important steps to improve quality and address variation through the setting of consistent national standards and through the development of national clinical access policies. Our role as the accountable commissioner for these services is not going to change, and NHS England will continue to be responsible for setting a national framework of mandatory standards, service specifications and clinical access policies, as we have done for the last 10 years. But the creation of integrated care boards, which operate now on a much larger footprint to the old CCGs, combined with new powers in the Health and Care Act from 2022, do provide an important opportunity now to address fragmented and siloed commissioning arrangements that have arisen as a result of often quite artificial splits in commissioning responsibility between NHS England and ICBs. And maybe I can just kind of illustrate that a bit with a few examples. So if you take adult critical care, to start with. So roughly 50% of adult critical care activity is commissioned and paid for by NHS England, and that relates to those services where placements relate to a specialised service. The other 50% is commissioned and paid for by ICBs. That doesn't lead to, collective joint planning terribly easily. If you take renal services, ICBs are responsible for commissioning primary and secondary care services for patients with chronic kidney disease, but NHS England is responsible for commissioning renal replacement therapy, so renal dialysis. So again, a kind of slightly odd split. Maternity services and neonatal services, which are inextricably linked. ICBs commission maternity services, NHS England commissions neonatal services. Mental health services, inpatient mental health services, learning disability services and autism services. NHS England commissions the inpatient specialist care. ICBs commission community services. And maybe finally, as an example, neurology. NHS England pays for anything that happens to take place in the neurosciences centre, whereas ICBs pay for anything that takes place in a DGH. So I think hopefully that illustrates some of the slightly fragmented commissioning responsibilities we've got. So back in February, the board approved plans to delegate commissioning responsibility, not for the whole portfolio, but for 59 specialised services to 9 statutory joint committees formed between integrated care boards and our regional NHS England teams. And that was really as a transitional step towards delegating full responsibility for suitable services to ICBs from 24 onwards, April 24 onwards. So we're now coming back to the board to agree our plans for 24-25, and in summary, we are proposing to move forward with delegating full commissioning responsibility for 59 services, so the same set of services that have been subject of joint commissioning arrangements this year, to ICBs across the east of England, Midlands and the North West regions. And to maintain joint commissioning arrangements just for one final year with ICBs across London, South East, South West, North East and Yorkshire regions. And that reflects, I think, a different level of confidence amongst those ICBs and regions in pressing ahead with delegation. So we want to support those regions and ICBs that are feeling confident and want to really progress and see the benefits. And we think it's absolutely right to give those other areas a little bit more time to make sure that we see a smooth transition. So just a few final points. These recommendations, I think, are consistent with kind of a careful and considered approach the board, I think, encouraged us to take in this area. I think they could see the benefits, but recognised that this isn't an insignificant shift in responsibility. And all of these decisions have been informed by really thorough assessments of system readiness that have been conducted jointly between our regional teams and in partnership with our integrated care boards. Finally, as we prepare for implementation, I think it's just worth highlighting 4 areas in particular where we're paying particularly close attention. Firstly, ensuring our expert commissioning capacity and capability is retained within the system as we make these changes. Secondly, making sure the new financial architecture and financial flows don't lead to any loss in financial control and that there are no sudden or destabilising impacts on providers. Thirdly, making sure that the necessary data and business intelligence requirements to support effective commissioning are in place. And lastly, that we do have robust oversight and assurance mechanisms in place for those services we are delegating. Thank you.
Thank you. I mean, very clear. One, the paper was very clear and very good. And secondly, that presentation was excellent. So thank you very much for the key issues. So reactions or comments on questions? David, and then Mary. So David first, then Mary.
Thanks, John. I agree with Richard about it being clear. I was trying to work out, though, the convergence policy and what that meant. And I couldn't work out whether a lot of those that were showing plus were actually the places with big specialist centres in them. And the ones that were minus were the places without them. And it just made me think about the practicalities of how that was going to work.
You might want to hold your answer till we get. So, Mary?
It makes a huge amount of sense to me, and I think it's very well explained. I just wondered whether you could give us a flavour of anything that's going to be kept at the centre.
Mm-hmm. And then the question I have is, without naming the tertiary specialist hospital, you and I met yesterday afternoon with one of the trusts, and one of the points they made actually after you stepped out was just to question about whether, I'm not sure how it would work, but whether there's a de minimis protection in terms of services commission that they would specialise in, on the grounds that as you, because it was a category rather than a particular condition, a category of population, is there a danger, was their question, that as we delegate these responsibilities down into the ICBs, that the pressure of the budget of the ICBs, because we're essentially dividing what might have been centrally as specialised commissioning, is splits into essentially into 42. Under budget pressure, do they simply let some of those smaller cost items against the over budget fall off the table? And it's just a question of how, I probably haven't explained it very well, but how well do we protect against that? We're an aggregate at the centre for a population of a particular cohort of the population. Actually, it was quite clear that you could see from a central basis commissioning enough resource, but divided by 42, does it actually get through? Mm-hmm. And they were concerned that actually, without some sort of de minimis protection, pressures on commissioning budgets in ICBs might damage the financial support to commissioning for that cohort of patients. Long-winded, rubbish question, but or not very well explained question.
So let me try and take them in order. So firstly, David's point about distance from target. So actually, what I didn't mention is to support all of these changes, we are moving now and have moved this year to a population-based approach to funding specialised services and away from the historic approach, which has been based on a provider basis on historic activity levels. That is a really, really important step for us to take in terms of actually supporting health inequalities, and potentially the most important thing structurally I think we can do in specialised services to support that. There will probably be all sorts of different reasons why some are below and high, and I think it's absolutely the case that we have seen that those patients who happen to be living close to a specialised hospital might tend to get better access to those services, and I think this now begins to let us look at all of this. So what we've set out in that annex is, actually how far from over or above, under or above target, ICBs are when you look at that funding on a population basis. And then we will need to very carefully look at how we begin to move those ICBs towards target over the course of, probably quite quite a number of years, and that will be heavily dependent on future government funding decisions. So we will be really cautious in that approach, and I think I can say for next year that we would expect every ICB to get a minimum level of growth. So I think that's important to say. Second point about what's kept, well, actually quite a lot is kept. So the portfolio, 150 services, if my maths is right, that's about 80 services that are left. Most of those are what we refer to as highly specialised services, and they tend to be services that we are commissioning for a very small number of patients, often kind of around 500 patients, often a very small number of centres. Sometimes, it might only be one or two centres across the country, and we recognise that the benefits of delegating those are much more limited. So they will all be retained and commissioned essentially by NHS England nationally. There is a small set of services, about 30 or so, that we are still yet to take a final view on whether they should stay with NHS England or be delegated, and we will make sure that we've taken final decisions on that by April 25, which is the point where we will look to delegate across the country the remaining services. And then, Richard, finally,
you understand my question?
Well, I'll answer. I'll provide an answer.
To the question you think I should have asked.
So I think people would rightly be worried if we were moving to arrangements whereby our providers were ending up having to have relationships with 42 ICBs, and that's absolutely not what we're planning at all. So, and that's why the decision the board took around joint committees this year, 9 joint committees, I think is really important, because what we will see is effectively 9 geographies where ICBs come together to commission those services jointly, share, pool risk, and so on. And that will avoid a situation where some providers are going to have kind of contractual relationships with 42 different areas. So I think that's really important. It varies around the country depending on the size of ICBs. But in terms of the areas that we are looking to delegate from April next year, in the Midlands, we're actually looking at an east-west split. So those services will be commissioned on that basis. In the Northwest, because of the size of our ICBs, they have actually done a lot of really careful work to look at which of the services in that portfolio of 59 can be delegated and organised at an individual ICB level, but which ones need to kind of have a pan-ICB approach. So slightly different in the Northwest, and then in the east of England, I think all the ICBs are coming together as per this year into a kind of joint commissioning approach, with all of the areas being supported by our current commissioning teams throughout 24-25.
Very good. Any other comments or questions? John, thank you. Really clear. Thank you very, very much. Yeah. So if I just ask the board to note, there's directions from the Secretary of State on national obesity audit, which I'm asking the board just to note. That was issued to us in November. Actually, just as a sort of a side comment, I think it's 28% of the UK adult population is obese. I think we are the most obese nation in Europe, if I believe the newspapers. I don't always believe the newspapers, but on this occasion, I think I would believe that. And obesity causes, I think the latest estimate from I think it was a Blair Institute piece of research, actually said it's 100 billion, of which 19 billion is the cost to the NHS. And obesity, we know, musculoskeletal issues, cardiac issues, diabetes too, 13 cancers are triggered by it. It's a very, very significant problem in our society where a lot of the causes of it lie outside our control. But I'm assuming the board is happy to note the direction on national obesity audit. So can I go quickly round on, is there any other business that people want to raise? In which case, can I just then, the next meeting is the 1st of February, 2024, and it's going to actually take place in the east of England. I won't narrow it more down, and won't narrow it down more than that at the moment. We're heading east. I would just like to reiterate what I said at the start, which is just to again acknowledge and thank Susan Kilsby and Rakesh Kapoor and Munir. Thank you hugely, actually, for an immense contribution to the work of the NHS England board and to the NHS. And you've been an absolutely sterling colleague, so thank you. I was going to say sort of
Can
best.
I just have one thing to
you
that?
may.
Sorry, just because while we're thanking people, because I think I forgot earlier, and I'm really sorry, but in welcoming Emily to the board, we should have just thanked Jim Mackey, who stepped in to cover the Chief Operating Officer role from David Sloman leaving and Emily starting. Obviously, Jim continues to work with us extremely closely on elective recovery particularly, but incredibly grateful for him for stepping up and indeed for his ongoing support and hard work.
Well said. No, he's been brilliant. And then I was going to say sort of best wishes for Christmas, although it's still 3 weeks or so away. But also I do feel slightly awkward because winter is a real challenge for the NHS. We're getting as ready as we can. We've had a long conversation about that. But still, I think it's best wishes for Christmas. And then just my huge thanks to the board. Not often seen, actually, the amount of work the board does outside this boardroom. And that's not just in general interaction in through the systems, into trusts and into the primary care practices where we meet, and also liaising with other arms of government and other constituencies, be they think tanks and so on. We had, as we know, dinner last night with, and 3 of the think tanks joined us, which was very good. But actually, if I think about the committees that we have, whether it's the Audit and Risk Committee, whether it's the CFO Advisory Group, whether it's People and Remuneration Committee, whether it's the Data, Digital and Technology Group Committee, Workforce Training and Education Committee, and the Quality Committee. Now, it sounds slightly bureaucratic, but it's not at all. They all oversee, with non-executive director challenge, important aspects of the work of NHS England. It's not seen, but it's a huge amount of work done by the board. And particularly in a year when actually we've combined 5 entities and 4 boards, so consolidated the agendas that are otherwise looked at by other separate boards and consolidated those and have managed those, and it's a unitary board or set of unitary board committees here. So my huge thanks to all of the non-executives actually for all the work that they do. And of course we've established another committee, which is the new board, the Genomics Board, which I think is also really important given the transformational potential that genomics activity can have in the way we offer care. So thank you very much. At that point, can I call the board to close? Thank you.